Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
I'd like to turn to a question that I don't think is controversial for us, but I think is worth underscoring. And that is, you have a patient who has molecular testing that includes PDL1, and it is 80%. It's in the high range that suggests that they are likely to benefit from Keytruda. They saw it on television. They hear about it on TV, in the news, et cetera. And they have EGFR mutation testing, and it's positive. I know that there are some oncologists who say that once you get PDL1 back, which often comes back well before anything else, you have a target, you can go after that. Let's talk about what is the role of immunotherapy in patients with high PDL1 and an EGFR mutation, not just first line, but does that change where you'd place immunotherapy in the sequence that follows?
Absolutely changes it. And that's what we've been talking about. So with high PDL1, without an EGFR mutation, response rates are somewhere around half of patients are going to benefit. And if you add chemo with it, you're going to, 70+% of patients are going to benefit. If you have an EGFR mutation, it's only maybe 10%. But if you have if you give someone an EGFR targeted pill, response, like 70-80+% of patients are going to benefit. So clearly you can have 80% of patients benefit by giving them an EGFR drug, or you can have 10% of patients benefit by giving them an immune therapy. That's pretty obvious.
Yeah.
The challenge is you have this immune therapy data, the PDL1 back first. If you start it, then your toxicity with the EGFR adding to that is really high. So we got to wait. Mm-hmm. And we see this even more with ALK. Very, very common ALK tumors to have high PDL1, they do not respond. There's only like one report I've ever heard of a patient with an ALK translocation responding to immunotherapy one.
It doesn't mean the same thing in these patients.
So if you get a PDL1 result back, especially if it's in a patient who has a very limited smoking history, and in others as well, you must wait. If the patient is way too sick, they have to start immediately. Okay, chemotherapy is never a wrong choice if someone must start today on treatment and you don't know their mutation status. But giving them immune therapy, especially if you have a high probability that they're going to have a target, I think is wrong. It's wrong. It's not the right thing to do.
Yeah, I fully agree with that. And I think one other point to bring out is really differentiating the fact that we're talking about the difference between giving immunotherapy in these patient populations in the first line setting and the second or later line setting, because we know that the tumor environment, meaning the landscape in which the tumor cells, the cancer cells sit in the body, changes, and the population of cancer cells change during the course of treatment with a tyrosine kinase inhibitor like osimertinib Tagrisso, like alectinib Alcensa. So that is what makes the difference here, we think, between what's happening in the first line setting and later line settings with these patients who have the targetable oncogenic drivers, and why we're so adamant about not giving immunotherapy in the first line setting, but waiting until the later line setting, because there's something that has changed within the tumor environment related to the immune environment specifically there that makes the cancer more responsive to the immunotherapy. And then also at that point, you're less likely to then be butting up against the toxicities that we've been discussing.
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly, Novartis, and Takeda. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate, and visit us for more information at cancergrace.org. Thank you for listening.